Hello and welcome. Today we're diving deep into a complex heart condition that can affect those who've undergone a heart transplant: cardiac allograft vasculopathy, or KV. Understanding KV is crucial for both patients and medical professionals, so let's explore what is, why it happens, and how we can manage it. So, what causes cardiac allograft vasculopathy? KV is essentially a form of chronic rejection affecting the blood vessels of the transplanted heart. Unlike acute rejection, which is more of an immediate attack, KV develops gradually over time. It's triggered by the recipient's immune system recognizing the donor heart as foreign, even with immunosuppressant medications. This immune response damages the lining of the coronary arteries, initiating a cascade of events that leads to thickening and narrowing of the vessels. Let's break down the pathophysiology. The initial immune attack damages the endothelium, the inner lining of the coronary arteries. This damage prompts an inflammatory response, attracting immune cells to the vessel walls. These immune cells release substances that stimulate smooth muscle cell proliferation and migration. This leads to the formation of a thick layer of cells and extracellular matrix within the artery wall, a process known as intimal hyperplasia. Over time, this intimal hyperplasia narrows the artery lumen, restricting blood flow to the heart muscle. What makes KV particularly challenging is that it tends to affect the entire length of the coronary arteries, diffusely and concentrically, unlike typical atherosclerosis. Now, let's talk numbers. Cardiac allograft vasculopathy is a significant long-term complication following heart transplantation. The incidence increases over time, with estimates suggesting that a substantial percentage of heart transplant recipients will develop KV within 5 to 10 years after transplantation. While improvements in immunosuppression have helped, KV remains a leading cause of graft failure and mortality in heart transplant patients. It is important to note that incidence numbers may vary based on the center and patient population studied. The signs and symptoms of can be subtle and often don't appear until the disease is quite advanced. Some patients may experience chest pain or angina, similar to what's felt with coronary artery disease. Shortness of breath, fatigue, and decreased exercise tolerance are also common. However, a significant number of patients may be asymptomatic, meaning they have no noticeable symptoms at all. This makes regular screening and monitoring essential for early detection. Diagnosing KV requires a combination of methods. Coronary angiography, a traditional invasive procedure, involves injecting dye into the coronary arteries and taking X-ray images to visualize blockages. Intravascular ultrasound, or IVUS, provides a more detailed look inside the arteries, allowing for accurate measurement of the vessel wall thickness. Doppler flow wire studies are also used to assess blood flow in the coronary arteries. Non-invasive methods, like cardiac stress testing with imaging, can also raise suspicion for KV and prompt further investigation. However, the gold standard is typically coronary angiography with IVUS. While there aren't distinct types of KV in the traditional sense, the severity of the disease is often classified based on the degree of narrowing observed during angiography and IVUS. The International Society for Heart and Lung Transplantation ACE grading system ED is often used to classify KV severity. In this system, KV0 indicates no evidence of KV, while KV13 indicate increasing levels of stenosis. Treatment for KV aims to slow down its progression and manage its symptoms. Immunosuppression plays a critical role, and adjustments to the medication regimen may be necessary. Medications such as statins, which lower cholesterol, and antiplatelet agents, like aspirin, are often prescribed to help prevent further narrowing of the arteries. In some cases, percutaneous coronary intervention, or PCI, such as angioplasty with stenting, may be performed to open up blocked arteries. However, because KV typically affects the entire length of the vessels, PCI can be challenging and may not always be effective. Repeat heart transplantation may be considered in severe cases where other treatments have failed. Preventing KV is a major focus. Optimizing immunosuppression to minimize immune activation is key. Maintaining a healthy lifestyle, including a balanced diet, regular exercise, and avoiding smoking, can also help protect the heart. Regular screening with non-invasive tests and angiography with IVUS is essential for early detection and intervention. Early detection of subclinical disease via routine angiograms allow for early medical intervention. The prognosis for patients with cardiac allograft vasculopathy can vary. Unfortunately, KV is a progressive condition that can lead to graft failure, heart failure, and death. However, with early detection, aggressive treatment, and close monitoring, it's possible to slow down the progression of the disease and improve outcomes. Recent research has focused on developing new immunosuppressive strategies, identifying biomarkers for early detection, and exploring novel therapies to target the underlying mechanisms of KV. For example, some studies are looking at the potential of EBI-TIOR inhibitors and B cell-depleting agents in preventing or treating KV. Continued research is essential to improve the lives of heart transplant recipients affected by this challenging condition.